Salam sejahtera diucapkan kepada semua hadirin yang dihormati. Selamat datang ke Syarahan Perdana Profesor Dr. Tan Kee Sin pada hari ini. Sila izinkan saya untuk bercakap dalam bahasa Inggeris untuk para hadirin dari luar negara. I would like to wish a very warm welcome to our distinguished guests, Professor Dr. Tan Kee Sin's family and friends, fellow professors, doctors, researchers, and colleagues to this very special event hosted by the Faculty of Medicine, University of Malaya. A very warm welcome too to everyone joining us on Zoom and those watching the YouTube live stream. I'm Professor Dr. Chin Ivan, and I'm honored to serve as the Master of Ceremonies for the inaugural lecture of my good friend and colleague, Professor Dr. Tan Kee Sin. Professor Dr. Tan Kee Sin graduated from the University of Melbourne, Australia in 1993 and obtained his MRCP UK in 1997. He completed his postgraduate internal medicine and general neurology training in the United Kingdom and joined University Malaya on his return to Malaysia. He was appointed Professor of Neurology in 2011. A professor's inaugural lecture is one of University Malaya's cherished traditions. This lecture honors the professorial journeys taken by our professors and provides an opportunity for them to share with us their wisdom, their inspirations, and their philosophies. Today, we have the good fortune to share this time with Professor Dr. Tan Kee Sin, a dedicated and gifted neurologist, an expert in stroke medicine, and an acknowledged leader in his field of expertise. Having shared an office with him for over a decade, I bear witness to his passion for his work, his care and concern for his patients, and his deep desire to contribute to the community and to the university. Professor Dr. Tan Kee Sin will be speaking on advances in the management of stroke, a journey in time. So to begin, I would like to welcome the arrival of the Honorable Professor Dr. April Camilla Roslani, Dean, Faculty of Medicine, University Malaya, accompanied by the Honorable Professor Dr. Tan Kee Sin, Professor of Neurology, Faculty of Medicine, University Malaya. Without further ado, we shall start this inaugural event with the national anthem, followed by our University of Malaya song. If I may invite you to take a seat, Professor April and Professor Tan. I would like now to invite the Dean of the Faculty of Medicine, the Honorable Professor Dr. April Camilla Roslani, to chair this lecture and introduce the Honorable Professor Dr. Tan Kay Sin. Please welcome Professor April.
Thank you very much, Mr. Chairperson, and a very good afternoon, as well as assalamu alaikum to distinguished guests, ladies and gentlemen, and of course, our inaugural orator himself, Professor Dr. Tan Kay Sin. It says something about the erudition required in the field of neurology that our last two inaugural lecturers have been given by neurologists. Today's orator is no exception. Professor Dr. Tan Kay Sin is a professor of neurology at Faculty of Medicine, University Malaya, as well as senior consultant neurologist at University Malaya Medical Center. As you have heard earlier, Professor Tan graduated from the University of Melbourne in Australia in 1993. He underwent internships at the Royal Melbourne Hospital before completing internal medicine training rotations in the Hammersmith Hospital, London, and the Royal Liverpool University Hospital. After successfully obtaining his membership of the Royal College of Physicians, he spent a further 2 years in clinical neurology specialist posts at the Newcastle General Hospital and in West Yorkshire, England. Returning to Malaysia in 1999, he joined the University Malaya academic family as a lecturer in internal medicine and neurology. However, in 2002 to 2003, Prof. Tan and his academic excellence found himself being awarded a Fulbright scholarship to undertake a fellowship in stroke and neurosonology at the Wake Forest University Hospital in Winston-Salem, North Carolina, under the renowned Professor Charles Tigler. Following this subspecialization, he set up neurosonology services and initiated acute stroke services in University Malaya, and this continues to expand in collaboration with interventional radiology. Thereafter, he speedily ascended the academic ranks in University Malaya with promotions to senior lecturer in 2005, associate professor in 2007, and full professor in 2011. Professor Tan has research interests focused on stroke, cerebrovascular diseases, and its related areas. In pursuing this, he has been a visiting fellow to the National Stroke Research Institute in Melbourne under the Australia-Malaysia Institute grant in 2008, working under Professor Jeffrey Donnan, and also a visiting research staff at the National University of Singapore in 2013, collaborating with Professor Jayasilan Kandaya from the Department of Biochemistry. He has numerous industry grants and is principal investigator for many international investigator-initiated studies. These studies have led to practice-changing findings, particularly in acute and secondary prevention of ischemic strokes. Other innovations included the use of transcranial Doppler ultrasound to detect microembolism in intracranial stenosis, as well as homocysteine lowering with vitamin B and folic acid in ischemic stroke patients. He was a member of the groundbreaking Nipah virus investigation team that won the Tun Mahathir National Award and the Merdeka Award in 2006 and 2008, respectively. Professor Tan is an accomplished speaker and prolific writer, publishing in many Tier 1 journals. He is an editorial board member for the Journal of Neurosonology and Neuroimaging. Academic leadership roles include that of past president of the Asia Pacific Stroke Organization and past president of the Malaysian Society of Neurosciences. His expertise and academic standing are recognized nationally and internationally through appointments as Fellow of the Academy of Sciences Malaysia, the Royal College of Physicians, Edinburgh, and the American Heart Association. It is therefore my pleasure to welcome Professor Tan to the podium to share with us his personal journey in time in the advancement of stroke management. Professor Tan, the floor is yours.
Thank you, Professor April, for chairing this my inaugural lecture today, and for the kind introduction. I would also like to take this opportunity to thank the Masters of Ceremony for this evening, Professor Chin Ivan, a friend and colleague over many years at the Department of Medicine, sharing an office and many previous assignments. A warm welcome to all the esteemed professors present, colleagues, family, friends, from wherever you are. Good afternoon and good evening. I'm happy that you're able to join me this evening. It is a privilege and an honor to give this inaugural lecture, a long university tradition and a significant milestone in an academic career. This lecture is several months in the making, and it's an opportunity for me to introduce, encapsulate, and now record in this COVID era my work and expertise for a larger audience. The difficult bit is what to leave out. So I would like to start this lecture with the outline of my lecture, which is my journey in neurology. But before that, I'd like to say that in Malaysia, stroke is treated also by geriatricians and internal medicine physicians in many parts of the locations in Malaysia. And in the United States, vascular neurology is the name of this specialty. In the UK, this specialty is called stroke, so stroke medicine. But the singular aim is to manage and treat strokes. So this is the lecture outline, and I hope it is of interest to colleagues in other specialties. So I will talk about my journey, advances in stroke management, and some of my research interests, as we have talked about. Now, I graduated in Melbourne in 1993, worked at the Royal Melbourne Hospital, and this is a historical relic from the past, and where all the interns had to sign and have their photos taken. And this is that's me there, yeah, at the bottom, alphabetical order. And after my internship, I went off to the United Kingdom for further training, and I worked in the south, the west, and in the north. And it's a lot of traveling and hard work in the UK. So some of the memories I have include working at the Royal Liverpool Hospital. This is the photo as I remember it, this old block of building, and even older Newcastle General Hospital. This is as I remember it. So after almost 4 years in the UK, I was happy to return home to the University of Malaya. Now, I joined Professor C.T. Tan, then the neurology unit head. And at that time, there were only 2 neurologists, Dr. Goh Kian Jin and Professor Tan. And the head was Professor Goh Kian Lee. And after I joined, I think three more lecturers joined. I think Dr. Chong Heng Tae, Dr. Vimalan, and Dr. Chew Ni Kong. And I think they've all left for better things. I'm the only one left. So moving on, I'm happy to say that to be a member of this is one of my first papers on Nipah virus. It's an interesting sort of condition when we have an unknown encephalitis in Sungai Nipah and Bukit Pelando. This is actually from the journal article. The distribution of the farming villages spared the Malay village and affected only the Chinese families. So this is unlikely to be Japanese encephalitis as was first thought, because it is a mosquito-borne virus. So the Nipah virus, as we all know, came from another source. So this is an interesting first paper that I had, and followed by some papers on the CSF in these Nipah patients. And I'm pleased to say that my colleagues, Professor Wong Kam Tong, Prof. C.T. Tan, and Goh Kian Jin, and Chua Kao Beng, we contributed to this paper in the Annals of Neurology. So I like to say, for those who can remember, other highlights include teaching in Hospital Klang, in Hospital Tunku Ampuan Rahimah. This is when it's all general medicine. And I remember they were all case-based learning. Each case stood by itself, and there were a lot of interesting science which the medical students had an opportunity to look at. So it's a whole month of teaching in Klang. And one of the other highlights is going to Kota Kinabalu. This is always a welcome relief because, we go there once a year because in Kota Kinabalu, there were interesting cases. We were there for a week to help in the neurology service. And of course, we had a seaside hotel and the seafood, which were a plus as well. So those were the old days. I don't think there's such a service anymore, and there's no teaching in Klang anymore. So interesting. So one of the things I learned in the early years in the University of Malaya, I had to learn this from scratch, include the use of transcranial Dopplers, where the use of ultrasound is used to insonate the base of the brain. And this is an interesting technology, and it was first described in 1982 with the use of a piezoelectric probe and using pulse wave technology to detect the flow of red blood cells. So this is not available in Malaysia at that time, and I had to go to Winston-Salem to sharpen the knowledge. So I got the Fulbright scholarship at that time and proceeded to a place called Winston-Salem in North Carolina. This is an old photo that I managed to find, thankfully. It's such a long time ago, but this is Charles Tegeler. He's still working. You can look him up in the internet. This is Patrick Reynolds, and this is the two fellows. Jong Yo Kim is working in Texas Tech at the moment, and one of the other fellows, Kristen Betterman, is a vascular neurologist at Richmond, Virginia. So these are some of my colleagues. It's been many years, and this is an interesting place actually, because I'd like to share with you that the U.S. is extremely big and relatively affluent, and however, there is this stroke belt. You can see the stroke mortality and incidence is much higher if you compare that to the West in California, in Washington State, and in the North in New England, Massachusetts. So these are much lower incidence and mortality. So in the South, there's an abnormally high, in the states of North, South Carolina, Georgia, Mississippi. So this, and this is an ongoing phenomenon which we try to explain, but some of the reasons could be because of the socio-economic factors, poor access to healthcare, also the diet, fried chicken, fried fish, and sweetened tea. There's the southern US have this sweetened tea which is twice the rate of Coca-Cola. So there's a lot of sugar in that. So these dietary factors contribute to stroke. And of course, Winston-Salem is also the home of R.J. Reynolds, one of the biggest tobacco companies in the world, up to the turn of up to the early 2000. So I think all these factors, smoking, have contributed to this increased mortality from stroke. So this is the background of North Carolina. This is the old TCD machine that we use. This is thrown. This is on the floor now. It's gone. So at the end of my sabbatical, I completed a fellowship and I sat for the neurosonology certification for the American Society of Neuroimaging. This certification is still available. It's easier now. You don't have to travel, and it's certainly something worth considering if you want to do transcranial Dopplers and neuro ultrasound. So the neurosonology service has grown slowly, and this is our new machine and a team of that do this service. We provide service to the neurosurgical wards, stroke patients, and also follow-up of many of our stroke patients in the outpatient clinics. So we do about 500 TCDs and carotid ultrasounds per year. So now I want to, this is a bit of an academic lecture as well. So I would like to say that TCDs, these are the less frequently used TCD users. So less frequently known. So in critical care, in ICU, we can investigate the perfusion pressure, and the waveforms tell us of raised intracranial pressure. And this can be used in the setting of ICU. And of course, not well known is the microembolic signal detection. This can be done using this head strap and this pencil probe. And you can lie down and have this done for an hour or half an hour to an hour, where you can actually detect this microembolic signal. This is the only technology that can actually detect embolism. So it is an interesting, you can see this high transient intensity signal. This is unidirectional. So this is a schematic diagram of how it looks like. And I have a video that I can share. Okay, you can see that. Yeah, that's the microembolic signal. Okay, so you can see that. And this is the M mode of the ultrasound. You can see the depth of the insinuation, and that corresponds with a signal as the emboli goes through. So this is quite remarkable technology. Nothing else can do this. So I've been fortunate to work with a few investigators in this area. And one of the first studies we were involved in was dual antiplatelet study with clopidogrel versus aspirin plus aspirin versus aspirin. At that time, this was before the major dual antiplatelet trials for stroke and TIA were done. So we wanted to see whether we could reduce this microembolism, which we can see with carotid stenosis or intracranial stenotic disease. So this is a paper from Lancet Neurology, and we found that dual antiplatelet reduces the microembolic signals from unstable large artery stenosis. So you can reduce it, and later on this became the underlying scientific basis for dual antiplatelet treatment for early TIA or stroke. So with this, I think I'm fortunate to meet Professor Wong again. Professor Lawrence Wong is now professor emeritus in the Chinese University of Hong Kong. This is a photograph in one of our meetings. This is in one of the palaces in Hyderabad some years ago. Okay, so so this is a fortunate collaboration I've had, and we've developed the ultrasound emboli detection service, which is still available and still being done in our lab. Now, recently I joined the Neurosonology and Neuroimaging editorial board along with a host of others. This is the Korean Neurosonology Society's editorial board. So we look forward to submission of neuroimaging and neurosonology articles. Now, I think for many years, I think it's an encouragement for young neurologists, young specialists to take part in local societies. I was for many years in the EXCO and was the president of the Malaysian Society of Neurosciences from 2008 to 2010. And this honed organizational skills and helped move to a larger platform. And I have been in the EXCO of the Asia Pacific Stroke Organization for a number of years, and we have. I have to tell you a little bit about this. We have spent some time organizing this regional society. So this is activities that we have done, and it is founded in 2011. We had a flagship meeting, which takes place annually, and it's a regional stroke meeting and provides platform for education and advocacy. Now, I also organized a meeting at the Asia Pacific Stroke Conference in 2015 in Kuala Lumpur, and I was the CME chairman for the Asia Pacific Stroke Organization several years ago, and a recent immediate past president. So I have been fairly busy with this society, and this is in the past many regional meetings took place, and I'm also pleased to say that we have unified these conferences. So there's only one regional stroke conference now, and for the last 10 years, we have organized meetings every year from Tokyo to Chennai. And the next meeting will be in Kaohsiung, Taiwan. So we look forward to more participation from all over Asia Pacific and from Malaysia. So now, other international activities, this is from one of our meetings in Malaysia, so some old photos. And of course, nothing, you should sum up all your activities in the last 10 years. I've done that in the 10th anniversary paper for the Asia Pacific Stroke Organization, and we summarize stroke care and stroke research in the Asia Pacific. Well, that's a subject of another lecture. So this is freely available in the internet, and this was only published, I think, 2 months ago. Now, Asia Pacific Stroke Conferences has been a place where we meet a lot of regional experts. This is Professor Bernard Young from the Royal Melbourne. He's a neurologist and a neurointerventionist, and he's one of the first of his kind, neurologist who also goes to the lab, the CAT lab. So, and I met him in Brisbane some years ago, and we've had many meetings where we have opportunities to exchange knowledge and a platform for the young neurologists to learn. So it's our EXCO meeting. This is Professor Lin, myself, Professor Ramani from Singapore, Manmohan Mandirata, Professor Huang, and Professor Yoon from Korea. So we have had a lot of opportunities for this, and I'm fortunate to have such a collaboration here. One of the other activities, please, I beg your indulgence. This is on talking about the things I'm doing, but I think this is something I want to share. I was a past chair here in this regional meeting of experts, Asia Stroke Advisory Panel. This was founded a long time ago, even before I joined neurology. And I was chairman in 2017 and 2019. And one of the initiatives we have made were to actually set up a website to put everything together. And one of our projects include 2 textbooks. We are all contributors there. This is, you can easily look at that. The ISBN is there, and these books are available. And this is a recent book which I have been editing, which is Case Reports in Neurology, Stroke in Asia, a collection of all the stroke cases that is of interest and have a lot of teaching points. So I'm pleased to share this with you. Now, we have had many, many meetings. I've lost most of the photos. These are some of the photos in Kyoto and Yogyakarta in Indonesia. So now I'm proud to say this case reports in neurology book, Stroke in Asia, Teaching Cases, has had contributions from our lecturers, our own cases, and which were presented in the Asia Pacific Stroke Conference. So all the academic work from this network of neurologists. So I'm pleased to share that, and hopefully it will be an inspiration for further ideas in other specialties. So now, after that journey, I think it's time I visit the main meat of this lecture, Advances in the Stroke Management, where I will talk about all the important developments in stroke. This is in time, in chronological order. So I want to talk about the stroke unit. The stroke unit has been developed only recently. It was described in the 1950s and the 60s, and it's only in 1991 when the first convincing benefit of stroke unit care was recognized, and the first trial shows benefit. Later on, there are systematic reviews to show overall benefits and reproducible in different environments, and clinical guidelines have recommended establishing stroke units. So this is the first major advance in the treatment of stroke, and all the guidelines, World Stroke Organization, all recommend a stroke unit. So all hospitals treating stroke should have this unit where we concentrate all our resources, nursing, monitoring units in one area for all the strokes, and that is certainly shown to improve outcome and remove complications. Now, this is all summarized in a Cochrane review recently. You can look this up online, but stroke ward is definitely better than a mobile stroke team, and it's definitely better than having a general ward for stroke patients. So this is the evidence, and time again, the main components of the quality in these units can be attributed to nursing care. So this is evidence-based treatment. So if you randomize stroke protocol to groups that have a protocol to manage fever, hyperglycemia, and swallowing in an acute stroke against a control group, we can find that having this multidisciplinary evidence-based protocols initiated by nurses lead to better patient outcome. So this is one component of why a stroke unit care, but it's not the only component. And so this is some of the importance in the stroke unit. Now, I have to mention a little bit on diagnostics in stroke. Without the CT scan, I think we will not be able to image the brain, visualize it. So I have to say that the Nobel Prize was given in 1979 for the CT scan, but that's not quite enough, because a lot of improvements needed to be made before brain imaging was even useful. So CT scan and the MRI, the journey for the MRI is even longer in time. So from the initial concepts in physics until the actual units that are built in the 1970s and 80s. So a long journey, okay, in stroke diagnostics. So the first MRI, this is a picture from Aberdeen. This is where the first MRI was constructed. This looks like a lunar module, a lunar landing module, but you can put a patient in here. So So Sir Peter Mansfield, we all know, has had the Nobel Prize in 2003, but he's famous for his slice selection and his mathematical principles and analysis in order to convert it to useful images. So a lot of improvements have been made since then, 2003, with faster speeds of MRI. And advances in semiconductor technology is crucial to develop the speed of the MRI. And where we are now, I'll just show you a picture. We are at 3T MRIs, and this is a 3T, and in neurology units or neuroscience centers that afford 7 Tesla, it's kind of experimental. You can see this is a cavernoma on a 3 Tesla and a 7 Tesla. So it's like looking at a black and white TV and a high resolution TV, at the same time. So the field keeps getting further and better, and to do research in this area, you have to have the equipment. So I'll stop there on MRI. So now, acute stroke thrombolysis is not a new concept. It has been visited in time a long time ago. This is a paper from JAMA way back in 1958. And they were already thrombolizing patients using angiograms. Of course, they did not have a CT scan. They couldn't image the brain, so they could not visualize what it was doing, what they were doing, what the brain was doing, what they could look at the vessels. And they used fibrinolysin, which is from bovine origin, and extracted from bacterial cultures. Now, this is a paper from 1958, okay, historical paper. And angiography was also, cerebral angiography was recognized early, but you are not able to visualize the brain, so they can only understand that recanalization is associated with a better prognosis. But there was no concept of brain and time, brain infarction and time at that time, because you just don't have the technology to look in the brain. So this is what they have at that time. It's all recorded in history. So now, a long time was spent looking at the type of agents that could help lyse the clot in cerebral infarctions. So it took a urokinase and finally RTPA, which needed some time to get the right dose, the timing. So all this was done with a very rudimentary CT scan at that time. So now, finally, when the technology was strong enough, we were able to do the trials. RTPA at 0.9 milligrams per kilogram is given 10% as a bolus and 90% as a 1-hour infusion. That's used worldwide. And so this is the evidence from 1995. Okay, so thrombolysis is not new anymore. It is old. It is an old technology. And ECAS-3, we wanted to know the time limit of the brain, of how useful RTPA could be. And we needed another trial to extend the window, and we extended the window again in 2012, but I will share the results with you after that. After this. So thrombolysis, these are the major papers. Those interested can read this up, but the key point is 4.5 hours is the limit for thrombolysis. And what happens if you extend beyond the limit? So we had to find that out through, this will probably never be repeated again. This is plain CT scan. And in those with RTPA, those thrombolyzed up to 6 hours have actually increased fatality. Okay, so against within 7 days. So there's a group that died very early, and at 6 months, those who survive in the RTPA group, they have a significant shift in their disability. Their disability is reduced. So we know the limit is 4.5 hours. So no one can extend above 6 hours unless you have better technology. So that's when CT angiography came in. We in the university had the foresight of putting the CT scanner in the A&E room. That was in the early days of CT scans. And now there were a lot of issues. The radiologists will know this. CT angiography Early issues include single row detector technology, the X-ray tubes generated a lot of heat, slow workstations. One of the CT scans, CT angiography scans that I looked at in the early 2000s took 20 minutes of processing, which is too long for any use. So finally, with faster computers, greater RAM, higher speed data transfers, and lower costs, we can now get beautiful images of the brain in the scanner. So this is fundamental for stroke. Without this, we will not be able to function. So now, at the same time, I'd like to share with you the timelines for major devices in thrombectomy. Thrombectomy failed miserably in the first when it first started, and it's only when the future generations of better stent retrievers and aspiration devices came on that we were able to treat these blood clots. And this is a slide from Mercy. This is the first slide where it's a corkscrew device that actually wrapped the clot and pulled the clot out. And this was had a lot of issues because the clot would fragment and migrate distally, and it would break up and cause more stroke. So it didn't work very well. Okay, so the technology had to move on. You have to lift your game and move to the next level. And it is with stent retrievers that and adapt technologies that allow the clot to be aspirated in one piece. So this is important steps. And after this was done, the long battle to prove it began. So you treat these patients within 6 hours. They would have thrombolysis, and they would have thrombectomy up to 6.5 hours. So, and there are many studies. They prove it all together in different centers. So these are all major stroke centers. To be involved, you have to be at the top of your game to be involved in these trials. So, most of these are European, American, and Australian centers. So it's proven that this is possible. This is possible. You can treat it within 6 hours. So this is an angiogram of the occlusion, and then the flow is restored. It's after thrombectomy. It is a gratifying feeling for the endovascular practitioners. So this is how it's done, and most of it is using CT technologies. However, not all ischemic strokes are large vessel strokes, and not all large occlusions are suitable. It could be very distal. There are now sort of devices that can go distally, that can actually pull the clot out. So the field keeps getting better. So, however, one of the major drawbacks for these is the cost. I think this costs more than cardiac stents, and I think with this kind of prices, not many patients can afford it. Okay, so but we do 1 or 2 cases a month, and so we had to move further. We had to find out what kind of patients can be selected, what kind of patients beyond 6 hours had further brain left that we can still do further work. So this is when the stroke technologies, the CT perfusion, where contrast is put in to look at the ischemic tissue, and MRI is used. I think in Malaysia, most of us use CT perfusion, where we look at the cerebral blood flow and the cerebral blood volume. If that is relatively good, but there's a decreased mean transit time and an increase of Tmax. This is jargon for penumbra. Okay, then this patient has a significant area that is able to be saved. So if there's a mismatch of at least 20% of the core, so you can actually define the core, which is infarcted tissue, and you have a living area that's still salvageable around it. So if it's significant, then we can select these patients for further treatment. So a lot of development has been made using software, AI software, like Rapid, and you can quantify these measurements very quickly, and you can use it to treat the stroke patients. So this kind of technology is available, but Rapid software developed in Silicon Valley is very expensive, and not many centers use it. So we use our own equipment, the equipment company's software, which may have some standardization. There's no standardization yet in this technology, but most of the trials have used automated software. So we can treat patients now, up to beyond 6 hours, but they have to be selected. You have to have the technology to evaluate these patients and then select them, because not everyone will benefit from further treatment. Okay, so with this in the background, I'm just pleased to say that I've had to use the entire neurology, we have had to use the neurology on-call service. All the neurologists had to go on call from 2013 to 2014 to have stroke thrombolysis. So it's an old service for a long time. And this is Dr. Sofia Jendra. She's endovascular. She's a neurologist, but has endovascular skills, and she helped us in the early days. And of course, Prof. Sharon is also doing stroke at the same time. And I'd like to also thank Professor Cairo. He's been here. If he had left for private practice, the entire service, thrombectomy service, would have collapsed. But he's not left it. He's continued to help and build it from strength to strength with more trainees. So this is an important service. Okay, but thrombectomy service is just one part of stroke. It's not the only part of stroke. And these are some of the pictures I'm going to share. So there's a flow, A&E, stroke activation, neurology on call, and then selection of patients, and then interventional neuroradiologies for further treatment. So the current status in Malaysia is we are not the only center who can thrombolize. There are many centers in KL. We were one of the first. This is a paper published in Singapore Medical Journal. We have started in February 2012, and we've done some work. And we have competition from Sarawak, where Dr. Loh Wan Chung is working, and has thrombolized more patients in his city. And in Kelantan, they are also doing this service. So there are, there are centers that are doing this now, and but very few centers that have thrombectomy. And I think UMMC is one of the thrombectomy centers. Now, after you have a thrombectomy, after you have a stroke, the patients need to go to a proper environment, and that's when the stroke unit is important. So where they are monitored and for many complications, and that would improve their chances of future recovery. So there are a lot of challenges that I like to share. Perhaps the low number of neurologists to patient, 1 in 323,000, okay. Problems with beds and nurses, so high patient to nurse ratio. And we have not inadequate resources for the complete implementation of stroke units. So this is to remind us again the benefits, and also to say that centers can be divided into 2 centers. First, we have a primary stroke center, which is interested in neuroscience, interested in stroke, can perhaps thrombolize, but do not have the full facilities. And these full facilities are deemed comprehensive stroke centers, at least in the US. And this includes advanced imaging. You need, this is MRI, MRA, CT perfusion. This is slightly older, but you need to have all these advanced imaging techniques. You need to have a service. So if there's no neurology service, then there's no comprehensive stroke center. Okay, you won't be able to select your patients and take the call. So this 24-hour access is important, and ICU, we have expertise, we have a large neurosurgeon cohort, and we have a strong rehab facility. So we can be considered a comprehensive stroke center. So this is important because in the future, stroke patients can be thrombolized and sent for thrombectomy in a comprehensive stroke center with a lot of communication between these two centers. So this is how it's evolving in the more advanced countries. Now, another important development is stroke prevention. And this is a quick slide on direct oral anticoagulants. And this is 10 years of DOACs, and it is probably in non-valvular atrial fibrillation replace warfarin entirely. It has a better safety profile and better endpoints on systemic embolism. So this is a major advance I'd like to share. And the last slide is on some emerging technologies. If you read the journals, there are so many, but this is something that I think will be important. This is a trial from Texas, the USA, and they equip ambulances with a CT scanner, and they can actually diagnose a large vessel occlusion, and they can give thrombolysis in the ambulance itself, and that cuts the time tremendously. And this is where cities or centers that have good emergency medical services, good ambulance services can leverage upon, and it's better outcome in stroke units compared to A&E because the timing is much better in giving thrombolysis. So mobile stroke unit is one advance. It may be some time before it comes to Malaysia or even feasible because the cost is probably significant. But the next thing is, of course, if you live in Norway or Australia, they can put a CT scanner in the helicopter, and then you can scan the patient while you're transporting the patient out to the thrombectomy centers. Okay, so this is how things can develop. It's only combining the technologies you have and making it mobile. Okay, and the last slide is on tenecteplase. This is a new agent. It's been around for a while, but it's given as a single dose. So whereas TPA is given over 1 hour, which increases the timing of complete lysis, tenecteplase can be given as a bolus. So that cuts down the time to lysis very much faster. So this is used in India. India uses a generic version of tenecteplase. This is not approved for acute stroke yet, but I think it will be very soon, okay? Because the evidence of its equivalence with RTPA is fairly strong. Now, intracerebral hemorrhage. This is still a problem because there's no treatment. But I'll show you the slides of the hemorrhage. This where the hemorrhages expand. Some are superficial, some are deep. Okay. And one of the recent advance for this is something for the neurosurgeons who this is the technology of this minimally invasive surgery for aspirating and thrombolizing, clearing this clot without collateral damage to the brain. So the sizes keep getting smaller, and so but the evidence is not out yet because the strategy is still unclear. What is the best approach? What type of hemorrhages? So that's being worked out. So I think in the future it will be speed as well, and followed by some minimally invasive technique, which will improve and remove the clot very quickly to reduce the damage in intracerebral hemorrhage. So I share with you this is the next level in prevention. So you have because we have a lot of risk factors all going together in a patient. There is the concept of the polypill, where you put in all your hypertensives, all your lipid lowering, and aspirin into one pill. And this is a recent study from Salim Yusuf in patients with intermediate risk they have these multiple risk factors, and if you've given them this combined polypill, it leads to lower incidence of cardiovascular events compared to placebo. So these are intermediate cardiovascular risks, so they may have hypertension, undiagnosed diabetes, and in certain areas where access to medications are poor, so you can have one pill that will sort out all the risk factors or the major risk factors. So this is a proof of concept that will shift the odds to favor health. So I'll stop there because it's supposed to be the highlights of the stroke advancement. I will switch gears to research interests and contributions that I think is important. And for a long time, my interest is cerebral infarction in the young. When I did my sabbatical in Melbourne, Australia, I collected data on young strokes and compared it with an Australian Melbourne cohort. And the thing that struck us was the risk factors differences were significant. Australia versus Malaysia, and we also had higher proportions of large vessel disease and small vessel occlusion. So the risk factors are different from in the young, and in this young I mean under 50 years of age in the literature. So now in Malaysia, we have a National Health and Mobility Survey from 2006. This has shown a continuous rise in vascular risk factors, especially diabetes, dyslipidemia, and obesity, and some reduction in hypertension. And this is a recent paper published in Global Heart, a database from hospital admissions from the Ministry of Health, detected a substantial increase in incidence of those under 65 years of age, with the largest increase those under the age of 40. Okay, so the strokes are getting younger in Malaysia, at least in the Ministry of Health, and this is an important area and target group in Malaysia. I suspect most of the epidemiologists know this already, but there should be a stronger concerted effort to target these risk factors in the younger group. So this is another study that I've had a chance to participate in. This is across Asia, across all the major Asia-Pacific countries, 8 cities, urban areas. These urban areas have a lot of risk factors, a lot of large vessel disease, and so substantial presence of premature atherosclerosis in the young strokes. Okay, this is back in 6, 7, 8 years ago. And what does this imply? If you have a stroke at a young age, there's a rising socio-economic impact because the patient is unable to return to work. And this is a recent paper published a few months ago, and from our stroke database, young stroke database, we find that less than 50% of young stroke patients actually return back to work. So, and they will live a long time, but they are unable to work. So the socio-economic cost is substantial. So this is an area where the prevention will prevent rising socio-economic impact. Now, the median age of Malaysia is in the 30s. So if you cut the population into 2 different parts, divided at the middle age, Malaysia is about 30-something, okay? Japan is up to 50, okay? So parts of Australia, 40s, okay? So this tells us our age. So in Malaysia, the challenge will be from 2 age groups. We have a gray tsunami. This is a cartoon picture, a gray tsunami, where the geriatricians will probably have seen this before. And the healthcare budget is unprepared for this, okay? And also in parts of Asia, we have strokes in young adults. So the challenge from these 2 age groups may overwhelm the health budget from the side as well. So it's totally unprepared. So I think this is an area for further work and further public health importance and emphasis. Okay, now, not all stroke trials are successful, okay? Stroke trials have been unsuccessful, and one area of failure is on neuroprotection. So every single trial failed in this. And in the early years, I've had an opportunity to be involved in this neuroprotection study. So you give this to prevent the stroke from going further or reduce the ischemic damage. And this is a NXY059 from AstraZeneca. And it's a great concept because it's a free radical scavenger. It reduces the free radicals generated from ischemic damage. It's given by infusion. It was very successful in its early studies, a small study. But after doing a larger study, it was unsuccessful. There's a major disappointment after initial success. And in retrospect, we probably did not know, knowing what we know now, we probably had no information on the vascular status. It's also unclear if the agent is actually going into the brain. You have an occlusion there. You're not sure. So time will tell whether if you're doing a study limited by the technologies of the early era, you cannot overcome the problem. So in retrospect, that was the best we can do, and we can probably do better now. Okay, so although it failed, we've had an opportunity. I've had an opportunity to meet. This is Professor Hans Christoph Diener. He's a German neurologist who participated, or one of the major investigators in many of these studies. I mean, he's participated in several of these studies, and every single one of them failed. Every single one. So for 10 years, this is not translated, despite some good animal data. So we're not sure what went wrong, but the next generation of neuroprotection is being looked at. And that includes things that reduce inflammation, like used in multiple sclerosis, like fingolimod and metformin. Simple things now. Okay, so these agents may be revisited in the future because we're able to open the vessel. So if we can open the vessel, we can put these neuroprotective agents in, which may help the brain. So this is still an area in progress. So that means future trials will mean that you will need to participate. You must have the infrastructure to be able to participate in this trial. So if you don't have CT angiogram, you are unable to access the top technologies of the time, then I don't think you can participate as a center. Okay, so this is where we are at as an academic institution. We have to be at the top of our game in order to attract grants. Okay, so moving on. I want to also say that this is microRNA research. I've had a great collaboration with several investigators in this area. This is a microRNA. I think I'd like to just quickly say that microRNA binds to messenger RNAs. It prevents protein translation, okay? And it is an intriguing candidate for expression patterns. You can actually detect the expression pattern before the phenotypic projection of disease. So this makes an interesting target because it is further upstream from the translation of the genetic information. So it is great for prognosis, diagnosis, and therapeutic. This is in theory, if you understand it completely. We don't quite understand it, but this is a ribosome, and the messenger RNA goes through and it's read, and the transfer RNA puts the amino acid in and builds up the protein. So microRNA binds to this complex and blocks this protein translation. So which microRNA is important because you can then regulate this ribosomal complex. So this master, if you know who the master is, this key, you can actually use it to remove it, or you can block it. So this is results in messenger RNA decapping and decay. So the there's no protein translation. So microRNA and in the brain, there are a lot of changes, and there'll be a lot of microRNA being produced. So understanding this will help you understand how to block ischemia. Okay, so this is another area that has potential. It's promising, and however, it is more complicated than that because before this translations, these protein changes occur, you have to get the changes early. So you have to sample the patients as early as possible to know what are the microRNAs involved. So and before the proteins change. So this is a study with Jayasilan Kandaya and Professor Wang Chi-Woon, who they're both retired some time ago. So we found that there are consistent microRNAs that regularly associated with ischemic stroke, okay, from our blood sampling. But this was done within 24 hours, 24 to 48 hours, and within 7 days. So the challenge now is to sample the patients as early as possible, okay? So you need a big team to actually do things like that, and a lot of funding. So hopefully in the future, these will be key points in modulating treatment for the future. So, however, the potential microRNAs work two ways. They can facilitate or they can block. So there's a very complicated process that is not fully understood yet. And so there are agents that activate detrimental pathways, but also triggering organized response that counteract tissue injury. So this is various factors. It can help or it can not help. So the whole mechanism is not completely worked out. If you have worked out, then you can try to improve the protective factors while reducing the detrimental factors in the ischemic process. So I like to acknowledge, some of this work from Professor Wang, Jayasilan, students Yong Fung Ling, Tan Jung Rong, Arun Arumugam in the past. Okay, and work from UM again. I worked with Elsa Hanifa in the past, and we looked at homocysteine because homocysteine is an important but neglected atherogenic and thrombogenic agent compound in experimental animal models. So this homocysteine actually confers risk factors, an independent risk factor for ischemic stroke. And the TT genotype elevates homocysteine levels. So we found that in Malaysia, the TT genotype is an important determinant of homocysteine in Malaysian ischemic stroke patients. There's some studies from, more than 10 years ago. And at that time, I was doing this trial because I was convinced that homocysteine lowering would improve the outcome of stroke patients, reduce the recurrence, and we participated in this study for almost 10 years. Okay, it's a 10-year study where we gave vitamin B and folic acid to patients with ischemic stroke and followed them up for as long as we could. This is coordinated by Professor Hankey from Perth and Christopher Chen from Singapore. So 123 medical centers, 20 countries. So, and we thought we were onto something, and we will become famous because we can change the outcome of prevent stroke. But it was not better than placebo. Okay, so after 4,000 patients, almost 10 years, this is the result. So extremely disappointing. But however, I still think it's biologically possible. So in my daily practice, I still give patients folic acid and vitamin B. And I think 5 years later, I think the Chinese did a larger trial, folic acid in primary prevention with patients with stroke prevention in patients with hypertension. This is not well known because it's not well publicized because folic acid is inexpensive. So there's very little to gain from it if we prescribe it, right? Certainly for pharmaceutical companies. So so we studied this. The Chinese studied 10,000 patients. Only in China can you get 10,000 patients, and over some years the trial is better organized. It's enriched with stratification with genotypes. Okay, so and they measured the homocysteine level, and so mistakes from the past were not repeated. Okay, they looked at the earlier trial and looked at all the weaknesses and included all the important points that may not have been included, had a larger sample size. This is a positive study because it was terminated early because of a significant benefit. And these patients were observed, these benefits were observed in patients with low baseline folate levels. So ischemic stroke is reduced with the folic acid treatment in those with lower folate levels. Okay, and they also discovered the genotypes associated with this. So I think we should continue to use folic acid and vitamin B on the basis of this, and it's greater also in groups of groups that have high cholesterol levels. So the take-home message is, once a trial is designed, you are locked in by your numbers and the technology and your resources at that time. But in the future, looking at the trials that failed, better design, a targeted group, genotyping, and larger numbers can actually ensure further success. So I've come to the last part. This is a recent interest of mine. This is Moyamoya disease. So this is not a common stroke. It is Moyamoya disease is first described in Japan. It is an idiopathic stenosis of the terminal internal carotid artery and middle cerebral artery and anterior cerebral arteries. And this ring finger protein is an important gene. And many studies have found that if you find this mutation, the risk of Moyamoya disease is increased significantly, up to an odds ratio of 507 times. Okay, so we've not looked at it in our population. This is Moyamoya disease, collateral formation from internal carotid artery occlusion. And this is what it looks like in the angiogram. So these patients can have strokes or they can have hemorrhage. And this is our study here. We sampled a whole host of patients, Moyamoya disease, Moyamoya syndrome, intracranial stenosis, and control. This was delayed by COVID because patients were not followed up as regularly. So, and the key findings, these are my collaborators, Professor Ng Ching Ching and Professor Fong from pediatrics. About 30% of Malaysian Chinese Moyamoya disease patients have this gene variant. So it's consistent with Chinese, Japanese, Koreans. So I think it's not found in other groups, but I think knowing the gene is important because future treatment will depend on it. So I look forward to a larger study in the future in this area. So this is to acknowledge my study team. So I will conclude now. I've discussed my own journey in research and development at the University of Malaya. I've examined the journey of stroke treatment and its incremental components, its failures, and ongoing challenges. And so it's an exciting time in stroke treatment, prevention, research, and things will continue to improve. Research standards will certainly be higher for high-impact research publications going on to the future as the field improves with greater technology, and we have to keep up. So the greatest challenge now is to translate these advancements and best practices to benefit UMMC, and every strata of the community. So with that, the last few slides are on acknowledgements for my colleagues, the neurology service. This is the largest neurology center in Malaysia. This is the full complement. And all of us go on acute stroke call. I have to thank my colleagues for the support. You see, it's certainly not possible for 1 or 2 stroke neurologists to do this service. So I would like to thank them. Okay, we have, these are some of our specialties. Dr. Imran Idris, one of our lecturers, is overseas, and Dr. Shi Jiping has just joined. And I'd like to thank also the past and current lecturers, trainees. This is Dr. Fong is still with us, but she's a former trainee. Dr. Lau has just left, and these lecturers help run the stroke service. Without their help and their enthusiasm, the stroke service would not be possible. Okay, so now I'd like to thank Prof. April for chairing this meeting, Prof. Chin for being masters of ceremony, all the event organizers, the technical team, the development unit and visibility unit, which I'm told Associate Prof. Wan Yusof, Wan of Sulaiman is in charge. This is all the equipment that you see that allows the transmission of this YouTube video. So members of the A&E, former heads of A&E, nursing staff from our stroke ward and our neurology ward, the whole host of lab techs. The neurology unit is so big that we cannot get all of them together for one photo. So we should certainly try to do that in the future. This is the neuroradiology team, Professor Cairo, all the heads of department from the past. This is Pon Lechumi, who is the head of the lab, allows the transcranial Doppler services to continue. Now, I'd like to end with a quote. Lastly, but not least, I'd like to thank my family for their support over the years. Without the support, all this work would not be possible. So I'd like to end the quote: "Don't judge each day by the harvest you reap, but by the seeds that you plant." Thank you for your attention.
Thank you, Professor Tan Kee Sin, for your very insightful lecture. Ladies and gentlemen, I would now like to invite Professor April back to the podium to summarize and conclude this inaugural lecture. Welcome, Professor April.
Professor Tan, thank you for sharing your journey through academia with us today. You have vividly illustrated what it truly means to be an academic clinician, from being willing to travel the world to acquire the clinical expertise to deal with the most complex cases, but concurrently developing the research skills as well as the network needed so that you can advance the management of your area of expertise in the management of difficult patients, to actually being able to collaborate across specialties, across departments, across institutions, but even across national boundaries in order to really make this world a better place for all of us in the years to come. I enjoyed seeing the photos from your early career. It reminded me that what is important to an institution really is its people, not the building, not having brand spanking new facilities, although of course that helps, but it's really the people who are willing to put in the deep work, to innovate, to collaborate, and again, to make an impact on the world. You have shown that so much has changed within our lifetimes. In your area or your field of expertise, that is acute stroke management. I remember as a student hearing my consultants talk about whether MRI is really here to stay, whether it was going to be cost effective. And here you are telling us that 3T is passé and we should really be looking at 7T. I also remember as a house officer when trying to get an emergency CT scan, you know, you had to be willing to sacrifice an arm and a leg. And even then, there wasn't really a lot that you could do in terms of, once the stroke was diagnosed, there wasn't a lot that you could intervene for. And yet now we're talking not just about thrombolysis, but thrombectomy. And it's wonderful to see that all of this has been made possible through innovation, but importantly, collaboration across specialties. And so with that, Prof. Tan, it leaves me just to congratulate you on your achievements so far, to thank you for all that you have done, for your patients, obviously, but also for us as an institution and for the country, given your international standing, and to wish you even more success in the future as we seek to continue being academics who impact the world. With that, thank you very much. Ladies and gentlemen, thank you for sharing your time with us, and I wish you a pleasant evening.
Thank you, Professor April, for chairing this lecture today. And thank you, Professor Tan Kee Sin, for your very memorable and inspiring lecture. Ladies and gentlemen, we would like to commemorate today by taking a photograph of all of us together with the attendees on Zoom. I would like to ask those who have joined us on Zoom to please turn on your camera and keep your pose until the technical team is happy with the photograph. Thank you. I think the technical team is happy. This concludes our event for today. Thank you for sharing this memorable moment with Professor Dr. Tan Kee Sin. God bless, and thank you again, everyone.